Next, in the tactical field care phase, we're going to look at sealing an open chest wound. Items required for this are an Asherman chest seal, 3-inch medical tape, a piece of plastic larger than the wound, and 2 14-gauge needles with catheter, one being 3 1/4 inch and the other being 2 inches in length. A penetrating chest wound can be caused by anything that may penetrate the chest, such as a bullet or a piece of shrapnel. The area of importance is located between the collarbone and the navel, and in between the 2 shoulders. If you are unsure if the wound has penetrated the chest wall completely, treat the wound as though it were an open chest wound. Some of the signs and symptoms of an open chest wound follow: sucking or hissing sound upon inspiration and exhalation, casualty coughing up blood, frothy blood coming from the chest wound, shortness of breath or difficulty breathing, chest not rising normally when the casualty inhales, pain in the shoulder or chest area that increases with breathing, signs and symptoms of shock, such as rapid or weak heartbeat. Check for both entry and exit wounds and remove the casualty's uniform and armor to look for anything that may have penetrated the chest wall. If there is more than one open chest wound, treat the one that you find first. Expose the area around the wound by removing, cutting, or tearing clothing covering the wound. If clothing is stuck to the wound, do not try to remove the stuck clothing, as this may cause additional pain and injury. Cut or tear around the stuck clothing. Do not try to clean the wound or remove stuck objects from the wound. Here, the medic comes upon the casualty with an obvious penetrating wound to the chest. First thing he does is cover the wound with his hand to impede the flow of air into and out of the chest cavity. While doing so, he utilizes his other hand to remove an Asherman chest seal from its package. Once the seal is removed from the package, remove the back and the gauze from the chest seal itself. When the casualty exhales, place the ACS in place by using the glue side against the skin. If possible, ensure that the valve is over the wound. Once this is done, take some 3-inch tape and secure the edges of the ACS. Once the wound on the front has been taken care of, roll the casualty over to check for an exit wound. If one is found, place your hand over it, just as before, and grab a piece of plastic that is larger than the wound itself. Place the piece of plastic over the wound and tape all 4 sides down with medical tape. Once this is done, help the casualty into a sitting position to help with the breathing process. If you do not have an Asherman chest seal, you can utilize any piece of plastic or occlusive material that will not allow air to pass through it. If you're going to utilize this technique, ensure the piece of occlusive material extends at least 1 inch beyond the edges of the wound in all directions. After this is done, if the patient begins to have an increased amount of difficulty breathing, then this is a sign and symptom that a tension pneumothorax is taking place, and the air pressure building up inside the chest cavity needs to be released. Begin by placing the casualty on his or her back. Grab the 14-gauge 3 1/4 needle and catheter. Remove it from its packaging. Take 2 fingers and place them just below the collarbone. While holding the needle and catheter at a 90-degree angle from the patient's chest, insert them into the patient's chest until you penetrate the chest wall. Remove the needle from the catheter, leaving the catheter in the patient's chest. Once the catheter is in the chest cavity, secure the catheter with a piece of tape, without occluding the hole at the end of the catheter. Once this is done, sit the patient back up and continue to monitor the patient for additional signs of increased difficulty breathing. If the patient begins to show signs and symptoms again, repeat the process with another needle and catheter. If the patient has a muscular chest, or if the wound is over a spot at which we would insert the needle, there is an alternate site at which we can perform the needle decompression. For this alternate site, raise the patient's arms and grab the 14-gauge 2-inch needle and remove it from its packaging. Keeping 4 fingers together, Place them into the patient's underarm area and insert the needle just below the bottom finger. Again, once the needle and catheter is in place, remove the needle and you should hear a hissing sound. Secure the catheter in place as we did with the other, and continue to monitor the patient as previously stated.